listening to the Business Talk podcast. I am your host Deepak. We are honored to welcome Dr. Sarang Deo, Professor of Operations Management, Deputy Dean, Faculty and Research, and Executive Director of the Max Institute of Healthcare Management at the Indian School of Business, as our esteemed guest on today's podcast. Professor Dev's research focuses on healthcare delivery systems, specifically examining how operational decisions affect health outcomes at the population level. His work spans a variety of healthcare challenges, including the influenza vaccine supply chain and ambulance diversion in the US, HIV early infant diagnostic networks in sub-Saharan Africa, and both formal and informal tuberculosis diagnosis pathways in India. He collaborates extensively with global public health organizations such as the Bill and Melinda Gates Foundation, Clinton Health Access Initiative, and PATH. Additionally, he is a member of the World Health Organization's Strategic and Technical Advisory Group on Tuberculosis. Before joining ISB Hyderabad, Professor Dev was an assistant professor at the Kellogg School of Management. He earned his PhD from UCLA Anderson School of Management and an MBA from the Indian Institute of Management, Ahmedabad, and a BTech from the Indian Institute of Technology, Bombay. Prior to his academic career, he gained industry experience as a management consultant with Accenture. In this episode, Dr. Sarang Deo explores his groundbreaking research, Bridging the Gap, how operations research save lives in public health, shedding light on how advanced analytical methods are transforming healthcare delivery and improving population health outcomes. Let's not keep you waiting. Please join me in welcoming Dr. Sarang Deo to the podcast. Dr. Deo, thank you for graciously accepting our invitation. It's an honor and privilege to have you with us today.
Thank you, Deepak. I'm excited to be here.
Professor Dev, could you start by explaining what operations research is and why it's so crucial in public health?
Deepak, that's a good question. It's a complex term and different people have different meanings for it. But as our community puts it, it's simply the science of the better. If you want to break it down, think about what operations is. Operations is how you get work done. And so operations research is researching how we can get our work done better. And the definition of that better could depend on the context. In some cases, better could mean less cost. In some cases, better could mean faster. And in public health, better could mean saving more lives or reducing deaths or disease, so on and so forth.
Professor, how do you approach translating complex academic models into practical solutions that directly impact health outcomes?
Deepak, I think the approach is actually the other way around, which is you don't take models and then translate them into practical solutions. You start by looking at what are the practical problems, and then you ask if those problems can be solved by first creating models that capture reality somewhat accurately. And then the next step, which is if the models generate a solution, how do you use that solution to move it back into the real world? But the first step requires a lot of effort, a lot of interaction with people on the ground, observations, because real world is very complicated. And any mathematical model is not going to capture the entire reality. So the trade-off there is how do you take most of the important phenomenon and create a tractable model. I can give an example if that's going to help understand this better. So many years ago, we did some work on diagnostic networks in sub-Saharan Africa to diagnose children or infants with HIV. And that had two different models or two different systems interacting with each other. One is how the disease progresses itself among infants. So there's a rate at which infants are dying or mortality is occurring. And then there is a separate model that takes the diagnostic network, which is you collect samples, you take those samples to the lab, then the results come back from the lab back to clinics. So that was modeled as an operational network. And then the way to combine these two is to say the output of the operational model is going to be the delay in getting the results back. And then that delay is fed into the disease model to then predict what the mortality would be. So the actions that you're taking are not related to treatment itself because you're not doctors. Actions that you're taking are in this world of network modeling to say which clinics should send samples to which labs, how much capacity should there be in the labs, which only affects the delay. But then you are able to calculate the impact of that on mortality eventually.
Can you share the key challenges faced in optimizing vaccine supply chains and how operations research addresses this?
Yeah, I mean, vaccine supply chains is a huge topic, Deepak, and each vaccine or each type of vaccine may present itself with different challenges. So when I started doing my PhD research many years ago in the US, the vaccine supply chain that was most problematic or challenging, or at least in the news, was the influenza vaccine, which is mostly given to adults and is given every year. So the challenges in that supply chain at that time were how do you manage supply of the vaccine in a short period? Because the flu season peaks around winter, and so you need to vaccinate people before that. And so that had very uncanny similarities with the fast fashion supply chain, where you're trying to stock up high fashion goods just before the selling season. And then if there are any leftovers, then you have to dispose them off. The interesting part in that vaccine supply chain was also that production was not under your control. It's a biotechnological product. So there was what we call as yield uncertainty. And so then we started studying the impact of that yield uncertainty or production uncertainty on the downstream delays, challenges in getting the supply. But if you come to India and start looking at the childhood vaccines, the routine immunization program that we run, the challenges can be very different. They could be more in terms of reaching the last mile. So one of the research projects that we are currently working on with a PhD student is understanding what are the benefits of extending a cold chain. So at the last mile today in many villages, you don't have a stock of vaccine. The vaccine comes periodically to the village in terms of a health and sanitation day when a camp is held. Um, but then if someone misses that camp in that month, the next camp may be held 1 or 2 months later, which then delays vaccination and puts the children at risk. So we are trying to understand if you were to build additional storage capacity, and this is cold storage, which is expensive, would it reduce the delay in vaccinating children? And again, thereby, would it prevent some vaccine preventable diseases from occurring?
Professor, what insights did your research on influenza vaccine logistics in the US reveal about improving distribution efficiency and equity?
Yeah, so I mean, the issue in US is that the distribution and logistics are very well set, Deepak. So the challenge there was actually much upstream, which is the number of manufacturers that were producing influenza vaccine had come down over a time from about half a dozen to just two or three. And so if any one manufacturer had problem in getting its production up because of contamination, because of yield issues, then there was a shortage of vaccine. And so, what our research did at that time was to say that the small number of manufacturers and production issues are not separate from each other. We showed using some economical modeling that this production uncertainty or the yield uncertainty could actually be one of the major drivers as to why manufacturers are exiting the market and resulting in a concentrated industry.
How have operations research method improved diagnostic network for disease like HIV in Africa and tuberculosis in India?
So, excellent, Deepak. I briefly talked about the diagnostic networks example in sub-Saharan Africa, where the main question was how do you reduce the delay between collecting the sample and then getting the results back to mothers about their children. And if we don't know the context very well, we may imagine that this delay may be because of poor transportation network, roads being not good, so on and so forth. When we spend a lot of time on the ground, we realize that the transportation delay itself was not more than few days, maybe a week, but it was still taking 2 to 3 months for the results to come back to clinics. And after a lot of discussions, observations, collecting data, we found that the drivers for delay were the processing logic at each step. So when samples are collected at the clinics, they are waiting for more samples to batch up before they can think about transporting, because transportation is expensive and uncertain available. When the samples come to the lab, they're also waiting for the samples to be batched up because they don't want to run a large machine, a DNA PCR machine for only a few samples. So those were the drivers for delays. And then we came up with an alternative configuration for the network where different clinics were sending samples to different labs so as to equalize the load on the labs and thereby reduce the delay. So that's the story on the sub-Saharan Africa diagnostic networks. When it comes to tuberculosis in India, again, the issue seems to be the same, which is delayed diagnosis. But again, a careful examination of the context told us that it was not because of logistics that there was delay, but it was the way patients were being diagnosed by doctors. So if you have TB, and you don't know that you have TB, obviously you are coughing, you have some low grade fever. And so then you go to a neighborhood doctor who may be an MBBS, who may not even be MBBS, maybe BAMS, BHMS. And they are going to think that you have either simple cold and cough, or you have some other respiratory infection. And they're going to run tests on you, or maybe just give you antibiotics, hoping that the infection goes away. But when someone doesn't get better, they move to another doctor, then to another doctor, so on and so forth. So the delay is because of inaccurate diagnostic practices, doctors' practices. So the approach we had to take there was very different. It was not to improve the logistic system, but it was to try and change the behavior of doctors so that they order more accurate tests, WHO endorsed molecular tests, as they're called. And then we could start measuring the impact of that on the overall delayed diagnosis.
Can you describe a case where systems thinking helped identify bottlenecks or gaps in healthcare delivery that were previously overlooked?
Some of these examples that I talked about would be applicable here. In fact, I'll give you an anecdote on this diagnostic networks in sub-Saharan Africa. The way the sample was being collected from infants was you take a spot of blood and then dry it on a blotting paper before you transport it to improve its durability, so to speak, right? So because otherwise fresh blood will get bad and you won't be able to test it. And people thought that this dried blood spots would help. When we went and observed the operations in the lab, we found the exact opposite, which is precisely because these samples would not go bad, they were being deprioritized in the lab as against other samples that were fresh blood samples. And so, after discussions with them, we could tell them that these so called locally optimal practices the lab manager was following were having a large impact on health outcomes of people and population at large. So that was one striking example. There's another one that involved again sample transportation in Malawi, where there was an NGO running a rider network across the country to collect samples. Um, and they had a fixed set of routes that the riders would follow every day. And 30% of those visits to health facilities were going waste because there was no sample to be picked up. And so we decided to change the way the routes were decided rather than predetermined fixed routes. We asked the health facilities to provide information on how many samples they have to be collected. And then we optimize the routes every day based on this data. Now, of course, you have to imagine that in Malawi a few years ago, you're not going to have smartphones or apps, which is what typically people think of. So we created a very simple low-tech solution using feature phones and what are called as USSD codes, where you punch a bunch of digits and then at the end you put a number that tells what the number of samples are. And then we ran a very complex optimization model based on all this data centrally, and then sent back the routes to the riders for them to implement.
Professor Dev, what role do you think data availability and quality play in designing effective public health interventions through operational research?
Deepak, that's a very important question. All the models that I've just described to you, they tend to be complex and they tend to be data heavy. So if you don't have good quality data, the recommendations from the models are likely to be not very good and appropriate. Of course, at times you can either adapt your model for available data, or you can also calculate or do analysis on the sensitivity with regards to missing data. And I can talk about two examples here. So in India, in Hyderabad, we worked with a social enterprise that was running diabetes screening for low income communities, a sort of urban poor segment. And the community health workers that went to these households to screen for diabetes or monitor diabetes couldn't run complex tests like HbA1c, which is considered gold standard. They were just doing random blood sampling. We developed machine learning tools and models to understand how well can we predict someone's diabetes status using very rudimentary data that is being collected. And we were able to show that if you were to apply models from the West, say guidelines developed by the American Diabetic Association on this incomplete data, you're going to get very poor results in prediction. But homegrown models, machine learning models that take available data from here can then accommodate these missing data more appropriately. So that's one example. The second example is the riders context that I just described a few minutes ago. And we were asking health facilities to report number of samples that they have using simple feature phones. And yet we found that over a period of 5, 6 months of running the pilot, up to 75, 80% of clinics were reporting this number, but we still had 20, 25% missing data. And again, we had to use prediction models to say in the past, they have said these many samples are available to be picked up. So even if they don't give me the number today, I can predict an approximate number based on that past data so that I can still run my routing model. It will be approximate. There may still be some wastage in the rider going to that clinic and not having samples to pick up, but it was better than not having any data or assuming that they don't have samples and hence they have not sent data. So you can come up with these mathematical approaches to deal with missing data.
Professor, how do you balance the need for mathematical rigor with the urgency and unpredictability of real-world health crisis?
Yeah, brilliant question. It depends, Deepak. So, if let's say the urgency is not of the kind of a pandemic, meaning, any health problem is urgent to be solved, but it is not so urgent that you have to leave everything aside, then we can follow a different approach. And the one that I have taken usually is to say, let's give practitioners a simple solution first and get it implemented. But then in the meanwhile, then work on more complex models, more sophisticated models, because if you can give them a simple solution, they feel more confident and they trust you more that this may be helpful to them. But then it doesn't mean that you leave the fixing of the system forever. You kind of take it as the next step. When it comes to something like pandemic, and we did work with several state governments during the pandemic time, I think you have to leave aside the research objective. So I can tell you an example. We worked with Punjab government when they were trying to reorganize their paddy procurement in mandis because those are very sort of crowded environments, and they were concerned that those may lead to more transmission of COVID during those times when everyone was practicing isolation. So we ran some simple models to show to them that actually reducing crowding at mandis and prolonging the procurement season could actually be worse because during that prolonged period, COVID is anyway spreading in the population. And those people who come to the mandi are now more likely to be infected. On the other hand, if you were to finish the procurement in a very short period, although there is crowding in the mandis, but the chance of someone being infected is very low at the early stages of the epidemic. I mean, that paper we've written, but we've never submitted because it was first important to get those insights to practitioners rather than to focus on the research process. So you have to make trade-offs at times.
Professor, what lessons from your research could policymakers and healthcare practitioners adopt to improve emergency care delivery?
It's a broad question, Deepak. I think I've been recently working with a group at ICMR that's taking a lot of effort to improve emergency care, urgent care across multiple districts in India. I think some of the basics are quite helpful. So if you think about ambulances as the main way to address emergency care, what operations research tells us is ways to calculate optimal number of ambulances if you want to give a certain level of responsiveness. Even what are the best practices in measuring responsiveness, right? It's not average time to the scene, but it is what percentage of ambulance transports arrive within a certain time period, be it 5 minutes or 10 minutes. And then where do you place ambulances, not just how many ambulances you have. There are cases, we did some project with EMRI a few years ago, where in their early days of operation, they were experiencing ambulance abandonment. And this is very unique in India because the population is not used to organized transport of ambulances. So they would call multiple ambulance providers parallelly, and whichever one they got, they would use that. And then other ambulances would come to the scene to not find the patient. So again, then we had to work through optimization models to say if patients have this kind of behavior, how do you reorganize your system? Where do you place ambulances? How many ambulances do you place at each location to minimize this problem? And it turned out that their locations were systematically different from the ones that we were recommending. And so, yeah, we can make those kinds of system changes.
Professor, I'd like to conclude this episode with one last question. Looking ahead, what emerging trends or technologies in operations research excite you most for the future public health impact?
Um, So, I mean, it's very difficult to predict the future, Deepak, right? But what I'm seeing on the ground, I think let's take it in two parts. One is in terms of technologies per se, right? Not talking about operations research. Everyone has been talking about machine learning and artificial intelligence, right? And I see a lot of excitement, also a lot of curiosity and anxiety about how they are going to impact health systems and patients. And I feel not enough attention is being paid to how these technologies will change decision making of doctors, workflows of clinicians and non-clinicians, and thereby have a positive or negative impact on patient outcomes. We ran a study a few months ago, I think a year or so ago, on whether first line doctors, physicians are likely to adopt an AI recommended solution for reading digital x-rays. And the common notion we have is areas where doctors have low skills, AI would be very helpful, and it makes perfect sense. What we found is doctors who were already more skilled in diagnosing were more likely to adopt AI, and those who had low skills were less likely to adopt AI. And so that starts to tell us that for us to have a real impact on health using tools like AI, you have to understand human behavior, you have to understand the system design. And that's where I think, again, the operations research, implementation science thinking can come together with the computer science approach of artificial intelligence.
Listeners, thank you for joining us on this insightful journey into how operations research is making a tangible difference in public health. From optimizing vaccine supply chains to improving diagnostic network and emergency care, we have seen how bridging the gap between academic models and real-world applications can save lives and promote equity. A big thank you to Dr. Sarang Deo for sharing his research and inspiring us to think differently about the power of systems thinking in healthcare. We hope this episode encourages policymakers, practitioners, and healthcare researchers alike to embrace these tools for better health outcomes globally. Thank you once again, Dr. Sarang Deo, for generously sharing your time and insight with us on our platform. Thank you so much.
Thank you, Deepak. My pleasure. Thanks a lot.